OH is defined as low blood pressure on standing. Diagnosis is based on the demonstration of a persistent and consistent orthostatic fall of at least 20 millimeters of mercury in systolic blood pressure, or of at least 10 millimeters of mercury in diastolic pressure within 3 minutes of assuming a standing position. The resultant inadequate cerebral perfusion is associated with a number of symptoms, including dizziness or lightheadedness, syncope, unsteadiness, and blurred or impaired vision, all of which adversely affect the quality of life of afflicted patients. Causes of OH include dehydration or blood loss, disorders of the neurologic, cardiovascular, or endocrine systems, and several classes of medications. Neurogenic orthostatic hypotension, or NOH, is orthostatic hypotension caused by autonomic nervous system malfunction. The autonomic nervous system and its sympathetic arm play important roles in blood pressure regulation. When a healthy individual stands, a gravity-induced drop in blood pressure is detected by sensory baroreceptors, principally the high-pressure baroreceptors in the carotid sinuses and the aortic arch. This information is then relayed to the CNS to provide a sympathetic response, resulting in the release of the neurotransmitter norepinephrine at postganglionic neurons. Norepinephrine then stimulates alpha-1 adrenergic receptors in vascular smooth muscle, causing vasoconstriction, and thus an increase in total peripheral resistance. Norepinephrine also stimulates cardiac beta-1 adrenergic receptors, leading to increased cardiac contractility and increased heart rate. The net effect is the restoration of normal tension within seconds of standing and maintenance of adequate cerebral perfusion. Patients with NOH have dysfunctional postganglionic blood pressure compensatory mechanisms upon standing. At a molecular level, the abnormality relates either to a deficiency of the sympathetic neurotransmitter norepinephrine or an inability of sympathetic neurons to release norepinephrine appropriately at the synaptic cleft. A variety of drugs with different mechanisms of action, including midodrine, fludrocortisone, methylphenidate, ephedrine, indomethacin, and dihydroergotamine, have been used to provide symptomatic relief for patients with NOH. Of these therapeutic options, the prodrug midodrine, whose active metabolite acts purely as a peripheral alpha-1 adrenergic receptor agonist, increasing vascular tone and thus blood pressure, is the only approved treatment for NOH. The limited therapeutic options and the incapacitating nature and frequently progressive course of NOH point to the need for an improved therapeutic alternative. Droxidopa is an oral synthetic amino acid precursor of norepinephrine that has the ability to cross the blood-brain barrier and was developed for the treatment of NOH. Droxidopa is decarboxylated by the enzyme dopa decarboxylase and is directly converted into norepinephrine both peripherally and centrally. The exact mechanism of action of droxidopa in the treatment of symptomatic NOH has not been precisely defined. However, its norepinephrine replenishing properties appear to facilitate recovery of decreased noradrenergic activity at the synaptic level, attenuating the decrease in blood pressure on standing and increasing blood pressure overall, which enable the maintenance of cerebral blood flow upon standing. Droxidopa has been approved for use in Japan since 1989 and in the United States since February 2014. Studies to date and marketing experience have demonstrated that droxidopa is safe and well tolerated in patients with symptomatic NOH associated with primary autonomic failure, in Parkinson's disease, multiple system atrophy, and pure autonomic failure, non-diabetic autonomic neuropathy, and dopamine beta hydroxylase deficiency. To date, short-term studies have shown that droxidopa significantly improves dizziness or lightheadedness, the cardinal symptoms of NOH. This study will assess the durability of the clinical benefit of Droxidopa in symptomatic NOH patients.